Mr. Chairman, ladies and gentlemen, I'll start by thanking Professor Khanna for the kind invitation to give us the opportunity to present about our work, comparison of long-term outcome with polyester versus PTFA graft material in aortic repair. Best graft haven't been designed, but a lot of lessons learned. Clinical community is diverse. On one end of spectrum are innovators and early adapters who are enthusiastic about adopting new ideas or late majority, and laggards who will never accept any solution no matter how many others use it or how promising it has been. Three individual innate traits that mandate our future goals and act as our natural differentiators are expertise, creative thinking, and intrinsic motivation. Prosthetic aortic replacement causes aortic remolding with circumferential strain, which lead to progressive distal aortic dilatation or dissection. All existing stent graft materials decreases wall compliance with higher wall resistance. A systemic review and meta-analysis of 17 studies with more than 15,000 cases to evaluate aortic stiffness represented by aortic peak wave velocity as a surrogate endpoint for cardiovascular disease found that aortic stiffness is a strong predictor of future cardiovascular events and all-cause mortality. You remember this paper was published in 2003, and it was from the Michael Marin group in New York, and mechanical failure of prosthetic human implants, and what they discovered that all grafts are failing. And what happened that the FDA have done a knee-jerk reflex and threatened to suspend all EVARs, and all companies went on to increase the stiffness of the graft by adding more stuff to prevent its failure. But they have forget the most important problem is the cardiovascular consequences. They found that the average time to fatigue for all devices combined was 13 months with suture fracture, graft holes, or stent fractures. This metal fracture fabric erosion with ultimate device early fatigue failure was the result of these two components. Multinationals have moved to more durable graft on the expense of aortic compliance. We know when we put an EVAR what's wrong with the sac expansion. Patients with expanding sacs have higher long-term mortality. And we know what's right with the sac regression. Patients with regression sac have highest long-term survival. So we know that type 2 may be innocent, but the problem of type 2 is causing the hygroma that cause problem with good graft. And then we have the type 3, which is graft failure, and so on. We know that aortic disease is a lifelong effects. More than double mortality rate of age-matched control at 5, 10, and 20 years post-aortic dissection. There is threefold increased risk of non-aortic cardiovascular death and any first-time non-fatal cardiovascular event and first-time heart failure. 80% that survive initial acute aortic event continue to have a substantial risk of aortic death, any aortic event, aortic intervention, and first-time diagnosis of aortic aneurysm. TEVAR and EVAR alter the timing of reflected wave with negative effect on left ventricular function, which is very important. And this is an example of pre-EVAR and post-EVAR. As EVAR and TEVAR increase vascular stiffness and induce left ventricular hypertrophy and diastolic dysfunction without corresponding elevation of blood pressure in acute and chronic phases. TEVAR and EVAR patients have significantly higher post-operative peak wave velocity measurement than those undergoing open aortic aneurysm repair due to loss of aortic wall wave propagation and plasticity, putting them at higher risk of cardiovascular morbidity. So what happened that you put the EVAR or TEVAR and they start failing. And we started having this tsunami of cases where we have to explant all the fenestrated graft, T-branch, whatever, and we have to do this crazy bypasses in the middle of the night with extensive revascularization. And the problem is that it's not only graft failure, it's aortic oscillation because of the problem with a very stiff graft in the aorta. The preclinical and preliminary clinical studies report acute stiffness of aorta following TEVAR, resulting in acute elevated pulse pressure, hypertension, reduced coronary perfusion, and eventually heart failure. And this is our museum with all the explanted graft because of the failure of they're doing the job. You put the graft in, they have type 3, because of the extensive oscillation, high blood pressure, and a very, very hostile environment. All EVAR grafts fail due to obsolete passé technology. And then we have to come in and do all this extensive reconstruction in order to save the patient's life and maintain perfusion to the iliacs and the SMA and the celiacs. However, we have missed something, which is the type 3 endoleak. And type 3 endoleak, because of the failure of this Zenesco graft or the AFX graft. And we have seen that day in, day out, and it's becoming a problem. And we have to find a solution for it. And I think the solution for it is to get a durable, smart endoprosthesis. Moreover, we have seen from Nelix, which has been withdrawn from the market after total failure, and the Ferris Endurant with a lot of fabric tear in the polyester graft. We have to start thinking ahead. We're doing a lot of 4D imaging. We have to go for 4D therapy. 4D MRI arterial compliance and tissue function is very important to understand how we have to design devices for the future. We understand fully that the loss of cell effect with alteration of pulse wave propagation result in adaptive left ventricular hypertrophy with loss of diastolic systemic blood pressure augmentation and reduced organ perfusion, mainly myocardial ischemia, despite absence of coronary artery stenosis. And this is lead to a problem with endovascular induced cardiac failure. The stent graft biomechanical properties are several orders higher than the of magnitude stiffer than the native aorta. Material enhanced durability to reduce risk of endoleak but stiffen the aorta. Aortic compliance critical to reduce impedance and cardiac workload. Patient developed AAA after having TVAR, which weren't aneurysmal before TVAR implantation, and I'm going to show a very clear example. AAA development is likely a consequence of amplified aortic wall stress and activation of aortic cell molecular dysfunction. Polyester-based aortic endograft causes a threefold increase in peak wave velocity compared to PTFE-based platforms, rate of which they developed AAA progression was alarming, worsening hypertension and late cardiovascular complications. So this is a patient came to us in 2009 with a thoracic aneurysm, put in surveillance. 2020 came with a rupture that required a TVAR. Remember, at that time, she had nothing in her distal aorta. In 2015, she came with a ruptured infrarenal aorta that required an emergency EVAR. So she had a TVAR, and then within less than 4 years, she came with a ruptured infrarenal abdominal aortic aneurysm that required an EVAR. And this is our collection for all the patients who had a TVAR and EVAR, have continuous chest pain, systolic hypertension above 170, unresponsible, and we went on high troponin, done a coronary angiogram. The coronaries are totally normal, and all the coronaries are normal. So we learned that combined thoracic endovascular aortic repair and endovascular aneurysm repair have very bad long-term consequences with altered cardiovascular hemodynamics. And we learned that non-occlusive coronary artery ischemia can lead to chest pain post-TVAR and EVAR. And patients who have TVAR must be monitored for development of distal abdominal aortic aneurysm and congestive cardiac failure. And this patient ended in a problem that required explantation of the graft. Aortic geometry, wall stiffness, blood pressure, and longitudinal systolic aortic stretching affect peak wave velocity, contributing to the biggest impact on wall stress. Computation model shows that all commercially available endovascular devices lower the aortic wall compliance after implantation. And we're starting to have a problem with obliterating endoaneurysmography, where we have to preserve our grafts. We tried to do a systemic review. However, we couldn't find any study that gives us a level 1 evidence the difference between any of them. However, we found that stent graft polymer should be strong, resilient, and capable of withstanding impact of normal pulsatile high flow arterial blood pressure. EPTFE and polyester are synthetic polymers that are relatively stiff and rigid compared to the native aorta. There was reduced early perioperative morbidity and mortality with endo option over open surgical repair. This advantage wasn't maintained at the long-term follow-up, and this implication is attributed to adverse impact of the stent graft material on cardiovascular hemodynamics. EVAR-1 trial, although not powered to demonstrate difference in outcome based on endograft, it showed reduced major adverse clinical events with ePTFE-based Gore excluder graft. Aortic implanting devices alter cardiac remodeling coupled with acute systolic hypertension, elevated pulse pressure, and reduced coronary perfusion. Post-EVAR and EVAR with polyester endograft, there are threefold increase in peak wave velocity and arterial stiffness compared to PTFE. PTFE endograft offers stronger resistance to dilatation than polyester-based endograft with lower complication of type 1, 3, and 4 endoleak migration and kinking. Polyester-based endograft are implicated in development of post-operative pyrexia, post-implantation syndrome, acute liver or multi-organ failure, and longer hospital stay post-EVAR and EVAR, compared to the PTFE-based endograft due to robust inflammatory response, endothelial damage, and increasing cardiovascular mortality. Polyester graft augments post-implantation syndrome with high interleukin-8 level, acts as a neutrophil chemo attractant that exerts pro-tumoral function and plays role in tumor progression and metastasis. We have published about the contemporary abdominal aortic aneurysm devices 3 decades of research and development with big data. Why had the best graft not been produced yet? It's a missed opportunity. Reducing profile of delivery system to make the technology more amenable to percutaneous access, thereby expanding customer base to other interventionalists. In their pursuit of market share, they compromised fundamental science behind design of a good endograft and jeopardized long-term durability with negative cardiovascular consequences. There are increasing evidence of adverse hemodynamic alteration post-EVAR and EVAR. Therefore, the best solution in the short term is to reduce the stented length of the aorta, while in the longer term, encourage continuous improvement in stent graft materials and design. And this have led us to the stuff that we have tried to do, which Petticoat, stabilized, flirt, and FIVAR, Ambivar, Candiplug, Nick Procker had increased cardiovascular mortality due to increase in arterial stiffness and left ventricular afterload with systolic hypertension. Decrease in standing length of the aorta by Tiger protocol is the only existing solution until new advanced compliant graft become available. Aorta is a functional organ which we should respect, preserve, and not eliminate. Regional aorta bioarchitecture varies considerably with implication for tissue function, and current device lack compliance and induce cardiac dysfunction. Next generation device must restore aortic compliance to reduce cardiac death. Mr. Chairman, ladies and gentlemen, arterial stiffness after EVAR explains the dismal long-term outcome. Arterial stiffness should be taken into consideration by the industry when designing new endografts. Patients after EVAR and EVAR are in need of intensive cardiac management. Thank you so much for the opportunity to present today at this fantastic meeting of the Asian Pacific. Have a good day.
Well, we should thank Sherif for a very thorough and most interesting presentation. And it certainly reminds me of many years ago, the same discussion in open surgery for polyester grafts, knitted or woven versus PTFE. And maybe we can discuss a little bit of his presentation later.